Shall I start?
One second. So a very good morning to everyone. All for our Saturday head and neck track academic class. So today's Nivedita Chakrabarty. Nivedita is a consultant radiologist in Department of Radiology, Tata Mill Center, Mumbai. She will be speaking on the radiological anatomy of thyroid gland and TIRADS grading. So we welcome you, Dr. Nivedita. Please go ahead with your presentation.
Thank you, ma'am, for the kind introduction. I'll just share my screen. I hope my screen is visible.
Yes, it is.
Okay.
Yeah.
Okay. So, hi, everyone. I'll be predominantly speaking on thyroid imaging, reporting, and data system on ultrasonography and the role of CT in thyroid imaging. I'm sure you guys are well versed with the thyroid anatomy, like it consists of two lobes joined by an isthmus. So I'm not delving much into it. I'll be subsequently showing you images of ultrasound and CT, so you can see the anatomy there. So the objectives, learning objectives will be to get acquainted with the description of lexicon with the help of ultrasound images, to be well versed with the recommendations based on TIRADS level, to be aware of the challenges and limitations of TIRADS reporting template, and to enumerate the role of CT scan. For example, in extrathyroid extension, tracheal invasion, tracheoesophageal groove invasion, lymph node, mediastinal involvement, and so on. So let's get started. So TIRADS was developed by ACR, that's American College of Radiology, in 2015 to provide ultrasound lexicon for incidentally detected thyroid nodules. Then there was a white paper on risk stratification in 2017 to reduce the rate of unnecessary FNACs and follow-ups. So this is the ACR chart, a TIRADS chart. So we can see there are 5 categories: composition, echogenicity, shape, margin, and just a minute, this is interfering with me. Echogenic foci. And all these categories have got further subcategories. And each of these subcategories are assigned points, as you can see in this chart. Now we have to add all these points after determining whatever the composition and echogenicity, shape, and margin and echogenic foci is on ultrasound, and then determine the TIRADS level. So you can see based on the points, the TIRADS level is given like TR1 to TR5. So TR1 is benign and TR5 is highly suspicious. And also further recommendations are specified on this ACR TIRADS chart, whether to FNA, whether to follow up, and what should be the size recommendations. And if you can see that the size recommendation goes on decreasing as the TR score or level goes on increasing. And so let's deal with each of these categories first. Like in composition, what do we mean by spongiform? So spongiform is composed predominantly, that is more than 50% of the small cystic spaces. So there may be septations, but more than 50% is cystic. So that is benign. Nothing needs to be done about it. If there's a mixed solid and cystic component, then points have to be assigned for the solid part of the nodule. And if composition cannot be determined, then we have to overcall it and assign 2 points to the nodule. Now coming to echogenicity, anechoic. By anechoic, we mean that the nodule is completely cystic. Nothing, no solid component is there, no septations, nothing is there. If it's hyperechoic, isoechoic, hypoechoic. Now echogenicity of a nodule is compared to surrounding thyroid parenchyma. But when we say very hypoechoic, that means we are comparing it with the strap muscles, adjacent strap muscles. If it is further hypoechoic to that, then we call it very hypoechoic. That's a highly suspicious nodule. And if we cannot determine echogenicity, by default, 1 point has to be assigned. Now coming to shape, we commonly speak about taller than wider. What do we mean by this? So on a transverse scan, when we are performing a sonography, if the AP diameter is more than the transverse dimension, then it is taller than wider and carries an ominous prognosis. Then coming to the margin, if it's lobulated, that means there are protrusions into surrounding tissue. Irregular means there are spiculated or jagged margins. And extrathyroid extension obviously carries an ominous prognosis, and we need to do a CT scan on MRI further. And if margins cannot be determined, then here we have to undercall and give a 0 point. For example, if the margin is ill-defined, then 0 point has to be assigned. And echogenic foci, of course, there are cometal artifacts. These are normal, so need not worry about macrocalcifications. That means large chunks of calcifications, throwing shadows, then that's macrocalcification. If there's a peripheral calcification, that means complete or incomplete along the margin can be there. Punctate echogenic foci, they carry an ominous prognosis. Now, let's have a look at the images. So as I told you, cystic, that means there's nothing. It's a clear. So this is the thyroid parenchyma, normal thyroid parenchyma. This is the left lobe. So here is the trachea. This is the left lobe of thyroid, and you can see that this is a nodule, which is completely black, completely dark. So nothing is there, no solid component, no septate, nothing. So the cystic, 0 points. Now spongiform, as I told you, more than 50% cystic components with septation. These are also benign. So if you can see my pointer. Just a minute. I think you can see my pointer. So the spongiform is like more than 50% cystic component, and there are multiple septations. So this is also benign. Nothing needs to be done further. And over here, when you see a solid and cystic component, that means you have to assign TIRAD score for the solid component. The rest of it is cystic, but this could be malignant. So you have to assign points for the solid component. And completely solid is given 2 points. So you can see this entire thing is solid component. No dark areas are present. So this is a solid component. Now echogenicity. Again, anechoic, only cystic component. Anechoic means it's only cystic component, no echoes in between. Hyperechoic, isoechoic. So you can see this is an isoechoic nodule, which is similar to the background thyroid parenchyma. This is the ICA. So this is a thyroid parenchyma, this is the nodule, and this is the ICA. So you can see it is merging with the background. So it is isoechoic. You can give 1 point. So hypoechoic, again, compared to the thyroid parenchyma, this has a lesser echogenicity. It is darker compared to the thyroid parenchyma. So it is hypoechoic. And as I told you before, very hypoechoic, you compare it with the adjacent strap muscle. So you can see this is the adjacent strap muscle. It is far more darker compared to the strap muscle. So it is very hypoechoic. And this guy is an ominous prognosis, and you have to assign 3 points to it. So coming to the shape, as I told you, shape is deciphered on a transverse imaging plane. And if the AP diameter over here, it is less than the transverse dimension. So it is wider than taller, benignish nodule. Now look at this. Here the AP dimension is more than the transverse dimension. So it is taller than wider. So it carries a bad prognosis. So 3 points have to be assigned to it. The margin here is smooth. Okay. And over here you can see ill-defined margin. You are not able to understand what the margin is, where the boundaries are. So, and if you remember in the previous composition part, we've told if the margin cannot be deciphered, then we have to undercall it and give a 0 point. Here you see there are lobulations. This is the nodule. There are lobulations. So it is a lobulated nodule. So you have to assign 2 points. Now here there's frank extrathyroid extension. This whole thing is a nodule, and you can see it is encroaching upon the wall of the ICA. So extrathyroid extension is present, 3 points. In such scenarios, you have to go ahead and do a CT scan. So ultrasound is an excellent modality for characterization of a nodule within the thyroid gland. And for any nodule extending outside for invading surrounding structures, you have to take the help of CT. And if it is indeterminate on CT, then MRI. Okay. So echogenicity, now these tiny cometal artifacts are fine, normal. We need not worry about them. Macrocalcification, you can see chunks of calcification. Rim calcifications, you can see these bright areas surrounding the nodule. So these are calcifications. And here punctate, you can see these tiny white dots. This is the nodule. And you can see tiny white dots. So these are small, tiny echogenic foci. Punctate calcifications, highly suspicious. Now there can be special scenarios, like if rim calcifications are present. So because of the calcification, the nodule can get completely obscured. So in that case, you have to by default place the composition as solid and echogenicity as isoechoic. And I've already told you if margin cannot be deciphered, then by default it goes into the category of ill-defined margin. And if echogenicity cannot be determined, it is isoechoic. If composition cannot be determined, then it is solid. And in mixed solid cystic, points have to be assigned for the solid component. Okay. Now, there are certain recommendations based on the TIRADS level, as we've seen. So if TR3 means we are assigning total 3 points. So what are the follow-up and FNA recommendations? If it is more than equal to 1.5 centimeter, then you have to follow up If it is more than equal to 2.5 centimeter, then FNA has to be performed. And what are the follow-up guidelines for TR3? 1, 3, and 5 years. Now for TR4, that means you're giving a score of 4 to 6 points. So if it is more than equal to 1 centimeter, then you have to follow up. If it's more than 1.5 centimeter, then you have to FNA. And follow-up interval is 1, 2, 3, and 5 years. And for TR5, which is the highest level, if more than equal to 7 points are present. So if the nodule is more than equal to 0.5 centimeter, then you have to follow up, and more than equal to 1 centimeter, then you have to go in and do an FNA. And annual follow-up for such nodules up to 5 years. Now you must be seeing that as the level goes on increasing, the size of the nodule that you need to FNA and follow up goes on decreasing, because the suspicion level also goes on increasing. Okay. Now, there can be scenarios when you have multiple nodules. So then two with the highest ACR TIRADS score, they should be sampled. Now, we are following up a nodule, right, based on the recommendations, ACR recommendations. So when are we going to call it significant enlargement? So if interval enlargement of follow-up is significant, if there's an increase of more than 20% and 2 millimeter in 2 dimensions, or a more than 50% increase in volume. So if the ACR TIRADS level increases between scan and interval scan, the following year is again recommended. So as you can see, the risk of malignancy goes on increasing from TR1 to TR5. So TR5 has got a risk of malignancy of 35%. Now, all of this, that is ACR TIRADS score, they have been developed to reduce unnecessary FNAs and biopsies, and also to judiciously utilize the available resources, because usually the differentiated thyroid cancers, they are indolent in behavior. So this ACR TIRADS was conceptualized. Now, but there are challenges and limitations to it. For example, you tell a patient like, look, I find there's a suspicious nodule, but it's like too tiny, not fitting into the category of, for FNAing it further. So we'll just follow it up. So what will be the patient's reaction be? Oh, I've got a malignancy, and this radiologist doesn't want to even put in a needle and go manage me further. So then the patient might want to get that nodule removed. So most of the times, this ACR TIRADS, category, it's not followed because the patient's decision comes into picture. Like you have to inform the patient about it, or you can speak to the clinician as to how to go about it. And if there's a strong family history of malignancy, now ACR TIRADS does not specify what to do if there is a family history of malignancy, for example, medullary thyroid carcinomas. So in such cases, any nodule that you find a bit suspicious, irrespective of the size, then you should go ahead and manage. You should discuss with the surgeons and the clinician. And what about the lymph node status? Like you don't not only have to nodes. Now, if you find, and also the not that suspicious, that you go ahead and suspicious and for the thyroid. These are the challenges come across. Thyroid carcinoma, thyroid cancer, and follicular carcinoma. Masses can papillary carcinomas performed to serve. So in nodule should be warrant ultrasonography. Nodal masses, thyroid origin, cystic component, calcification, thyroid or hemorrhagic content on CT one weighted thyroid nodal mets central compartment and the lateral 2 to 4. Plate should measurement of the P transverse diameter of the isthmus. Underlying thyroid parenchyma also. Nodules have to be lexicon. 4 nodules have to be included. There are multiple nodules and have to be specific whether to FNA requires to be done. So after update from ACR, but there has been an original validating ACR TIRADS and sensitivity similar ACR TIRADS scoring with a little improved spec. So we can start to to our nodules. And also ACR also has a calculator, like you can, wherein you can just put in the TIRADS on the calculator. So the website also has the TIRADS calculator. Now let's look at the role of CT scan. As I've already specified, CT scan is when there is a nodule outside the with boundaries of thyroid gland. Now CT and MR cannot characterize a nodule, thyroid nodule. Its role comes when there is extra thyroid extension, when you are looking at a surrounding structure invasion for lymph node at places where ultrasonography is inaccessible. So there the role of CT scan and MRI, they come into picture. And we all know this, that surgery is a mainstay treatment for any thyroid malignancy, except for the anaplastic one. So imaging plays a huge role, not only for diagnosis, not only for biopsy, but for surgical planning and also for recurrence detection. So the role of CT is extra thyroid extension for tracheal invasion. There are gradings I will show you with the help of examples, and also for indirectly deciphering the esophageal and recurrent laryngeal nerve involvement. Now, you cannot directly see on CT a recurrent laryngeal nerve involvement. That's to a tiny structure. But you can guess that indirectly. If there's a posterior extracapsular invasion, if there's a loss of fatty tissue in the tracheoesophageal groove, and of course, there is a hoarseness of voice, then you can gauge all this, that there is a recurrent laryngeal nerve involvement. And on CT also, the esophageal wall involvement is difficult to ascertain because generally the esophagus is not distended. So usually it is collapsed. But if you see a frank invasion, then fine. Or else these indirect signs can help you to come to a conclusion that, yeah, esophagus is threatened or a RLN may be involved. Now, prevertebral fascia involvement, yes, if there's a loss of fat plane between the vertebra and the malignancy, then definitely there's a prevertebral fascia involvement. But MRI scores better for assessing prevertebral fascia involvement compared to CT scan. Uh, okay, so let's look at the CT protocol. Now, before performing a contrast in a CT, please have a word with the clinicians and the surgeons, because the free iodide load of CT contrast medium injection, they interfere with the iodide uptake in the thyroid for at least 6 to 8 weeks. So for patients with differentiated thyroid cancer, this compromises the use of diagnostic thyroid scintigraphy and radioiodine ablation for 2 to 6 months. It's depending on the institution protocol. But the MRI contrast agent gadolinium does not interfere with the iodine uptake. Now, let's look at the grades of extrathyroid extension. So here we see a nodule which is completely surrounded by the thyroid parenchyma. This is a CT image. So this is how a thyroid gland looks on a CT, right lobe, left lobe. This is the isthmus. So you can see the tiny nodule is not visualized on CT scan. So you can miss multiple tiny nodules on CT scan. And as I told you, CT is not the modality to characterize a nodule. It is used for visualizing the invasion into the surrounding structures. Right. So if you can see a nodule which is completely surrounded by thyroid parenchyma, then it's a grade 0. Definitely there is no extra thyroid extension. Then in grade 1, a tumor in which the percentage of the tumor perimeter in contact with the thyroid capsule is 1 to 25%. Like here you see, it's just up to 25% in contact with the capsule. Then there is a grade 1 ETE present. Then grade 2 is when a tumor is in contact with the capsule up to 25 to 40%, 50% cases. So over here, this is the nodule, up to 50% of the nodule is in contact with the capsule. So this is grade 2 extrathyroid extension. And over here, you can see a frank extrathyroid extension when the contact with the capsule is more than 50%. As you can see over here, there's a capsule more than 50%. So obviously a grade 3 extrathyroid extension. Now, one of the studies have been done in our institute to grade or predict the tracheal invasion. That's known as the modified Shin grading. So you can see over here, grade 0 is when there is a more than 5 millimeter distance between the trachea and the nodule. So this is the nodule. So the normal thyroid is bright on CT scan. The nodule therefore will appear dark. Okay, so you can see this is the normal thyroid. Even in non-contrast CT, also the normal thyroid is dense, hyperdense, bright. And if there's any nodule, it will appear darker than the surrounding tissue. So you can see there's a more than 5 millimeter distance. So definitely there is no tracheal invasion, so grade 0. So over here, you see this is the nodule. Can you appreciate that bright thing? You can see fully over here in the left lobe of thyroid. But there's a half of it is obscured. So this entire thing is the nodule. And you can see it is abutting the external perichondrium of the trachea. So This is a modified Shin grade 1. Okay, in grade 2, the disease invades into the tracheal cartilage and destruction may or may not be present, as you can see over here. In Shin grade 3, the disease extends into the tracheal mucosa with no elevation penetration mucosa. So here you can see, appreciate that over here you just have tumor present, that cartilage lining of trachea is absent. As you can see over here, this white kind of structure, linear white structure, which is present on this side, is absent over here. That means the tracheal cartilage is gone, but it's not protruding inside the lumen, but it's just invading up to the mucosa. So this is a modified Shin grade 3. And over here, there is a frank extension into the lumen. There's a full thickness invasion with expansion of the tracheal mucosa and a bulge. So you can see posterior, this entire thing is the nodule, even extending posteriorly. And it's bulging into the trachea. So it's a grade 4 and obvious tracheal invasion is present. Now, role of MRI. So as I've told you, MRI is better for evaluating prevertebral fascia and for extrathyroid extension, recurrence, as well as for lymph nodes. Words about FDG PET-CT. Now, differentiated thyroid nodules, that's a papillary and the medullary thyroid carcinoma, they do not show uptake. So when there is a dedifferentiation into a higher grade, only then that nodule is going to show FDG avidity. So it is helpful in locating recurrence when whole body iRAD scan is negative in a patient having elevated thyroglobulin. So even if you see large masses and FDG PET-CT has been performed and you're not seeing an uptake, don't consider that this is not going to be a METS, because differentiated thyroid cancer, they do not show uptake. They can still be metastasis. What is the take-home message? The management recommendation, that is follow-up or FNA or none, that should be mentioned in the report as per the ACR TIRADS level. There are challenges and limitations of TIRADS which should be borne in mind, and discussion with surgeons, clinicians can help to reach a consensus. Then CT has a relatively good accuracy and specificity in the detection of extrathyroid extension, though the sensitivity is low. So any doubt on CT should prompt an MRI imaging for extrathyroid extension, because that will help in your surgical planning. Now, sensitivity of CT for diagnosis of tracheoesophageal groove involvement, which indirectly suggests involvement of esophagus and recurrent laryngeal nerve, is approximately 80%. So I thank my residents for helping me out with the images. Thank you. I'm happy to take any questions.
Thank you, Dr. Nivedita. Excellent lecture, very comprehensive and informative. I think if there are any questions, please post them in the chat box. Dr. Nivedita, I have one question that when we read the ATA guidelines, so usually that is the description that these microcalcifications can be sometimes confused with the other nodule. What is that? The nodules which are benign, which is can you help me, Nivedita, with that?
So nodules, microcalcifications, they are tiny calcifications.
That
can be seen. All the rest, like the goiter and all those, they have larger chunks of calcifications present. A microcalcification will not show those posterior acoustic shadowing. They are very tiny to detect, and therefore we don't rely only on one criteria. There are multiple criteria in place to decide. So tiny within the center of the nodule, only they are to be considered as microcalcifications. The rest are the comet tail artifacts. So they will have some, tailing, which I had shown you, a dot, and then there will be multiple tails, like a cone-shaped structure. So that kind of a calcification is benign. And over here, if there's only dot, then it's a microcalcification. But like as I said, we only don't rely on one criteria. It is a conglomeration of multiple criteria that we have to consider.
But
of course, it's not easy.
Specific.
Yes, most specific, definitely. And the ecogenicity, that is very hypoechoic one. And this microcalcification, that is highly specific, one of the important criteria to diagnose or come to a conclusion that this could be something suspicious.
Correct. I think, Nivedita, there is one question. When core needle biopsy is required in thyroid nodule?
Yeah, so it is as per the guidelines. Uh, Generally, they have specified FNA, not FNAC. So what they mean is that all the thyroid nodules that that fit into the category to be biopsied or tissue sampling to be done, they should be biopsied. That is, fine needle aspiration biopsy should be performed and not FNAC. We over here most of the times perform FNAC, and if highly suspicious, then it goes ahead with, if inconclusive on a pathology, then a biopsy is performed. But ideally, the ACR TIRAD specifies that all these nodules, which have that, they reach the threshold of that they should be biopsied, or tissue sampling should be performed as per the ACR TIRAD score, they should be biopsied. And therefore, they have not mentioned FNAC. It's FNAB actually. I think this, I can show you. Here you have the scoring system based on the score. Wherever it's written FNA, if more than equal to 2.5 centimeter size, based on the size and the points. So you need to FNA these nodules.
Correct. Nivedita, there is one more question. Ultrasound for parathyroid adenoma, can we advise for size above? Parathyroid adenoma, I think, would be a different subject altogether.
Yes, ma'am. So if we can see, we can visualize it posterior, because parathyroid adenomas can sometimes be intracapsular, sometimes be extracapsular. So posteriorly, if we can see another adjacent nodule which appears to be separate from the thyroid, then we can, raise the suspicion, get the blood tests done, and then we retrospectively think, yes, this is a parathyroid adenoma. It can be visualized on sonography, but this criteria is separately, completely different from the thyroids.
I think the question almost similar. Should we do a ultrasound guided FNA or only FNA? Okay. So should we, they are asking, should we do a ultrasound guided FNA always, or a simple FNA would be fine if it is a palpable nodule?
FNA, it's mostly recommended that in these tiny structures, you always do an ultrasound guided FNA, because you will target the nodule, at its maximum peak. And anyways, you are going to do get an ultrasound done for characterization of the nodule. So might as well in the same setting go ahead with FNA.
Yeah.
If it's a large nodule, obviously, if it's a large nodule, you can always, clinically and surgically do that. But the thing is, if it's for smaller nodules, which most of the nodules are, you would need to target the right area. So maybe,
So
because if
this,
if a nodule which is mixed solid cystic, you should not end up in targeting the cystic component. You need to target the solid part. So for that, you'll need a direct visualization on ultrasonography.
Exactly. So I think, like Dr. Nivedita said, I think it is better, if possible, to go ahead with a USG guided FNA whenever possible, when in the same sitting when you are doing an ultrasound. So is FNA sample sufficient to carry out further tests if required, like ISC, etc. In your experience, Dr. Nivedita?
No, IHC cannot be performed on FNA. So when they need that, they have to go ahead and do a biopsy.
Exactly. So whenever we need this thing, we usually have to do a FNAB, which is biopsy, because though more sample will be needed, and they need to carry out certain tests on that, for which certain amount of tissue will be required for staining. So FNA usually is not a good idea. So if there are any other questions, so I think with this we conclude today's class. I thank Dr. Nivedita once again. Thank you so much, Dr. Nivedita.
Thank you, ma'am.